and you can, with your goniometer, establish that you've created more external rotation on the table.
Okay.
What do you think it takes to keep that external rotation once the foot hits the ground?
Awesome question. Love that question. So we've already determined that this was, let's say it's a mobility deficit, correct? So we identified that there's a hip external rotation mobility deficit, passively and actively. They were limited before the session. And then we cleaned something up, manual work. We provided some sort of, neuromechanical change that, something let go, and we're able to get a little more. I try, and this is obviously pathology dependent and, case specific. And, if there's a load restriction and they're post-operatively with something. So, obviously in a perfect world, we're able to load them as much as possible. Thinking about how we can provide as much proprioceptive input to that joint complex, to those mechanoreceptors within that joint that we freed up, whether it's and understanding how to provide that input and how to progress and gradually increase it. So just to give you an idea, let's go along with that example. On the table, we're starting with maybe some, open chain. If, let's say, it was a hip flexion ER deficit, so 90 degrees of flexion, they had external rotation limitation. We're doing a manual resisted, activity of a combination of isotonics. They're concentrically moving manual resistance. I can grade the resistance and feel it. They eccentrically let go. They hold at end range isometrically. We're getting these motor pathways to lighten up. We're getting them to get neuromuscular fatigue within these pathways. And then, after we get some fatigue, after a dosage of whatever we feel is appropriate, we move on to maybe something else, open chain, then move into, something in a tall kneel position, a half kneel position, a high split position, a standing position, a single leg position, as much proprioceptive demand and complexity as possible, while, increasing motor recruitment for the musculature that are required to maintain that range of motion. Does it make sense? So it's a culmination of events, and using your own clinical reasoning and saying, well, this may be too much, not ditching an exercise if they can't do it at first, using our good verbal cueing, good external cueing, see if we can cue and coach them into the movement and have them proprioceptively figure out how to do it, and not ditching it right away. But then, taking a step back and saying, all right, maybe we need to take a step back and we'll stay here for a little bit, and seeing that's our endpoint, and kind of finding how far we can take the person, I found has had the best return on subsequent visits, later on in the plan of care.